Congratulations to Gloria and her team for putting on the National Hospital Transparency Conference. I'm honored to have been invited to participate. I also want to congratulate Gloria and her team for being the catalyst behind a rigorous examination of hospital prices in Indiana. The Employers Forum, of which she is president, sponsored a study by the RAND Corporation to compare hospital prices in Indiana with the prices in 24 other states. The conclusion of the study was that we have the highest prices among the 25 states, and our prices are literally twice as high as Michigan's prices. When I became aware of the results of her study, I immediately formed Hoosiers for Affordable Healthcare and asked Gloria to be a member of the board of directors with me. We knew that high hospital prices were being paid by working Hoosiers through lower wages. We also knew that high hospital prices made Indiana a less attractive place to do business. We immediately asked Brian Blase, a leading national healthcare economist, to put together a team to address high healthcare prices in Indiana. Brian had just left the Trump administration, where he was special assistant to the president for healthcare policy. Brian assembled such a team, which has developed proposals on how we can reduce hospital prices in Indiana. I'm honored to introduce Brian today, who will talk about the work we're doing. Thank you very much.
It's great to be with you. Let me start by thanking Al Hubbard for his leadership in forming Hoosiers for Affordable Healthcare, and Gloria for putting together today's conference and inviting me to speak. Let me start with the 5 key takeaways that Hoosiers for Affordable Healthcare made after delving into the data and meeting with a variety of key stakeholders. First, while commercial hospital prices tend to be much higher than Medicare across the country, they are exceptionally high in Indiana, particularly for outpatient care. And hospitals in Indiana are extremely profitable. Second, these high prices are not because Hoosiers are less healthy. Hoosiers are not significantly less healthy than people in other Midwestern states. For example, we looked at a dozen health metrics comparing Indiana and Michigan. The states were comparable. On half, Indiana fared somewhat better, and on half, they fared somewhat worse. Yet Michigan's hospital prices were half Indiana's hospital prices. And even if Hoosiers were less healthy, this should show up in greater utilization of healthcare. There should be minimal, if any, impact on prices. Third, employers want lower spending so they can increase wages and hire more workers. But the incentives for insurers are not necessarily aligned with the incentives of employers. Insurers are more profitable over time as healthcare spending increases. Insurers and third-party administrators have excelled at the discount shell game. They can tell employers how much of a discount they have received, but these discounts are off fictional, outrageous charge master prices. Fourth, in Indiana, roughly 70% of doctors are employed by hospitals. This leads to many referrals within those systems that limits beneficial competition. Earlier this year, the U.S. Department of Justice sued one major hospital system in Indiana for defrauding Medicare in an illegal kickback scheme that paid doctors large amounts to refer patients within the hospital system. Fifth, many stakeholders told us that Indiana employers have historically insisted on broad provider networks. This reduces their ability to get lower prices. We believe that there are significant steps that employers can take to lower healthcare costs, and this has been part of our work. One last important point on the problem. In healthcare, prices often perversely shape costs. Escalating prices have allowed hospitals to become productively inefficient and have then necessitated calls for higher reimbursements to catch up with higher costs. In addition to analyzing the problem, Hoosiers for Affordable Healthcare developed a set of policy reforms. Our main policy recommendations for 2020's legislative session centered on providing information to consumers and employers to help them be better shoppers of care. We analyzed drafts of legislation, advised policymakers and legislators, and testified in front of key committees in supporting reform efforts. The most important piece of information is upfront prices. Generally, price shopping has the most benefit under 2 conditions. when items represent a larger part of our budget and when there is wide price variation, and healthcare easily checks both those boxes. There are three main problems with shopping in healthcare. First, information problem. People lack price information. Second, incentives. People lack the incentives to utilize lower priced providers. And third, institutional problems. These are where markets in many parts of the country are highly consolidated, and that limits competition and increases prices. And you also have the doctor's referrals having an overly, all being very important. For example, people will often bypass many lower priced providers on the way to visiting the facility or provider to which they were referred. Now, price transparency clearly solves the information problem, but it also helps by creating better incentives and addressing institutional problems like facilitating competition between providers and by letting doctors know the prices of services for which they make referrals. There are three main benefits of price transparency. The first is to help consumers shop. This is especially important for people who are still below their deductible. We know that people who do shop in healthcare are able to save significant money. Second, helping employers establish better benefit packages. In a paper published by the Galen Institute a year ago, I explored this issue in depth. I wrote about models like direct contracting with providers and reference pricing designs. Third, price transparency is going to help employers monitor the insurers that they've hired to check whether those insurers are indeed getting good prices for those employers relative to other insurers. And fourth, putting pressure on high-priced providers. Now, in this area, the federal government has taken significant action. The Federal Department of Health and Human Services finalized a rule last November that requires hospitals to disclose their prices in a machine-readable format. It also requires hospitals to provide prices, including cash prices, for 300 shoppable services in a consumer-friendly format. This regulation takes effect in January, although some hospitals may be hesitant to comply because the penalty for non-compliance is only $300 per day. The American Hospital Association has challenged this price transparency rule in court, but it ended up losing in a district court in June. Now they've appealed. There is also a rule that would require insurers to provide price information, and the Trump administration is going to finalize this rule probably very soon. One of the reasons that states may wish to put these rules in state law is because litigation risk remains over the federal rules. It's possible that the courts will decide that the Trump administration has overstepped its statutory authority in promulgating these rules. Last year, Hoosiers for Affordable Healthcare recommended that Indiana codify the requirement that hospitals provide prices for 300 shoppable services. The state didn't adopt that recommendation, implementing an average price disclosure requirement instead. While average price provides some useful information, it's not as beneficial for employers and consumers as providing complete pricing information. At a minimum, the state should enact what we recommended last year. It could also consider imposing additional penalties on hospitals that fail to comply. Again, because of the litigation risks surrounding the federal rule, states should consider codifying the federal price transparency rules. Hoosiers for Affordable Healthcare second recommendation was that providers be required to provide a comprehensive, bundled, understandable estimate for all patients for scheduled care. The legislature did enact a good faith estimate, but only when patients request them. Many patients don't know that they can ask for a good faith estimate, or they may be intimidated to do so. The legislature should require that providers provide good faith estimates to all patients in advance of scheduled care. Almost every other industry provides consumers with good faith price estimates. For example, most times people go to the mechanic, they receive a good faith price estimate for future work. These estimates will also help nudge both providers and consumers to talk about prices in healthcare, discussions which are crucial for improved decisions. Next, surprise billing. Here, Hoosiers for Affordable Healthcare was looking for a market-based approach that protected patients and that also didn't involve the government setting the payments that should be made between insurers, hospitals, and doctors. Our recommendation, which was bolstered by several conservative and liberal health policy experts, was simply to prohibit balance billing at network facilities and for emergency care. This means that for the care delivered at in-network facilities, providers could not send bills to patients beyond what the insurer had agreed to pay. The legislature acted to prohibit balance billing at network facilities unless providers inform patients that they are out of network, provide a good faith estimate, and get the patient's written consent in advance. We believe the legislature should go further and also protect patients undergoing emergencies from balance billing. There are three other areas as well where our recommendations were largely enacted last year by the legislature. The first was broker fees. Employers and individuals need to understand the incentives of people selling them coverage. Some commissions are a function of premiums, which produces misaligned incentives, and this should be disclosed to payers. Next, the all-payer claims database. While Hoosiers for Affordable Healthcare had some concerns about the ultimate effectiveness of all-payer claims database, we believe they represent an opportunity to provide researchers and innovators with data to help both employers and consumers, and the legislature acted to start the process for setting up an all-payer claims database. On gag clauses, employers should have information about the prices that they are paying for healthcare. Gag clauses between hospitals and insurers are meant to keep the ultimate payer in the dark about where their money is going. While the legislature took steps to prohibit gag clauses, we need to ensure that this prohibition applies to all plans and includes existing contracts. Next, scope of practice limitations. These are annual issues that the legislature deals with. Too often, restrictions on scope of practice are more the result of incumbent and politically powerful providers acting to reduce the competition they face. Our goal is to allow providers to practice to the top of their skill set and ability. Last year, we recommended the state establish a process to allow employers and provider groups to challenge regulations that limit scope of practice. The process would produce an objective analysis of the benefits and costs of such limitations. We made this recommendation because we heard from many legislators that scope of practice fights are very confusing, with special interest groups providing a lot of conflicting information. They would value an independent and objective review. We continue to believe this recommendation makes sense. Improving appropriateness of care. While price is a key aspect of healthcare value, so is quality. Unfortunately, current quality metrics are largely ineffective. For one, it's fraught to question clinical decision-making in particular cases. Fortunately, an alternative approach to assess quality has been formed that assesses providers in the aggregate by using appropriateness measures which are developed in collaboration with providers. This information would basically allow providers to know where they stand relative to each other for doing the same thing. A renowned research team at Johns Hopkins University, led by Dr. Marty McCary, has developed such metrics. For example, they have developed metrics to assess opioid prescriptions after a given procedure, C-section rates for uncomplicated pregnancies, and the percentage of times a surgeon does back surgery on a patient without that patient seeing a physical therapist in the previous year. McCary and his team have demonstrated that such metrics provide useful information to providers who are practicing outside appropriate standards, and they can limit wasteful and unnecessary services. The state should open up Medicaid claims data to researchers for use in developing appropriateness measures and educating providers and patients. Finally, here are additional reforms beyond our initial transparency and information disclosure reforms. Pursuing interstate licensing compacts. Interstate compacts and model laws enhancing license portability make it easier for doctors, nurses, and other medical professionals to practice where they are most needed. The first interstate licensure compact on nurse licensure was initially implemented in 1999, and there are now 30 states that are part of that compact. Second, recognizing out-of-state and foreign medical licenses. The state of Arizona led the way with occupational licensing reform last year, recognizing licensing for professionals in good standing in the state where they are coming from. In addition, easing the licensing pathway for highly qualified, foreign-trained doctors is one step that could be taken to expand the supply of care and lower costs. Third, do not enact anti-competitive policies like certificate of need laws or certificates of public advantage. Fortunately, Indiana does not have any hospital-related certificate of need laws. Con laws raise prices, reduce competition, and lower quality of care. There's another anti-competitive policy that is gaining traction in some states, certificates of public advantage or COPA laws. COPAs limit the ability of antitrust enforcement agencies to challenge collaborations and mergers that create or enhance provider market power, and they likely inflict harm on consumers. Next, scrutinize proposed mergers for impact on competition. States can investigate anti-competitive actions. California has recently investigated Sutter Health System, which had a near monopoly on care in Northern California, for a variety of anti-competitive actions. Sunrise review of healthcare restrictions or regulations. This would require that all regulations enacted by the bureaucracy pass a rigorous cost-benefit test, and that any regulations imposed be done in the least costly way possible. Scrutinize and potentially prohibit anti-competitive contract provisions. It's becoming increasingly clear to employers that contracts between hospitals and the insurer or TPA can contain a variety of anti-competitive provisions that raise costs. These provisions generally limit the ability of an insurer to steer patients to lower priced providers or to exclude higher priced hospitals from networks. And finally, reforming the state employee health system. Last year, in several meetings, the state indicated to Hoosiers for Affordable Healthcare that the state would be putting out the state employee health plan for bid either this year or next year. This is an opportunity for the state to lead reform efforts, and we think there are 5 key steps the state should take. First, only enter into agreements with insurers who agree to transparency and accountability requirements. Second, insist on bottom-up pricing and refuse for any rates to be set as discounts from those billed charge master prices. Third, insist that the insurer pays identical amounts for services regardless of the site of service. Fourth, utilize reference pricing where appropriate, as the state of California successfully did for their public employees and retirees. And fifth, look for opportunities to directly contract with high-quality providers and to accelerate the use of cost-effective telehealth services. Hoosiers for Affordable Healthcare will be releasing further detail on these recommendations in the months ahead. Again, I'm very grateful for the opportunity to be with you today and brief you on the work and recommendations of Hoosiers for Affordable Healthcare. Thank you very much.